It's 12 o'clock now. Hello, everyone. I'm Austin Chen. I'm one of the internal medicine chief residents at the UW Montlake site. Thanks all for coming today to the Department of Medicine Grand Rounds, both in person and for those on Zoom. Really excited for our speaker today, whom we'll have introductions for in a minute. But if you are here in person on site, please come and join us in Turner Auditorium. That's in D209 of the Health Sciences Building. Yeah, food is allowed in the auditorium, so grab your lunch, swing on over. And then otherwise, if you're off-site, we love having you on Zoom as well. But I'll bring up Dr. Conrad Lyles here, who is our Vice Chair for Research in the Department of Medicine, to start our introductions for today.
Greetings, everyone. Welcome to Department of Medicine Grand Rounds. And this session of Grand Rounds is the Fialkow Scholar Award and Lecture. The Fialkow Scholar Award was developed in memory and in honor of Philip and Helen Fialkow. The department established this award to recognize and support a junior faculty member who shows outstanding promise as a scholar. And I have to say that this is probably the highest honor that we have in the Department of Medicine for our junior faculty. Dr. Fialkow was the chair of medicine from 1980 to 1990, and then became the dean of the School of Medicine and the vice president of the University for Health Sciences. He and his wife were trekking in Nepal when a tragedy occurred and an avalanche came down and buried them within their tents, and they passed away. This award was established to recognize in memory and honor of Dr. Fialkow and his wife, Helen Fialkow. They always had a strong interest in the progress of junior faculty, and throughout his career, Dr. Fialkow sought to identify mechanisms to promote and understand scholarship. So each year, we solicit nominations for the Fialkow Award from the divisions, and a committee of 6 individuals in the Department of Medicine then selects the recipient for that year. This year, we received approximately 7, we did exactly 7 nominations, which is actually a fair number of nominations. And the committee met and they selected this year's recipient. Here's a list of the past recipients, and you see at the very bottom, the recipient of the 2025 Fialkow Award is Dr. Jennifer Ross of Allergy and Infectious Diseases, Division of Allergy and Infectious Diseases. And to introduce Dr. Ross, I'll call on the head of the Division of Infectious Diseases, Dr. Anna Wald. I would say that not only do you get your name on a plaque and a certificate that will be prepared, but you also get $15,000 in a scholarship fund for your use for an academic purpose, your research, support of trainees. It's up to your discretion. So I'll turn it over to Anna now. The other point I wanted to make is also those people out there on Zoom, please, if you have questions during the course of Dr. Ross's talk, please put that in the chat, and then Austin will monitor the chat, and we can ask those questions at the end of Dr. Ross's presentation.
Thank you, Conrad. Well, it gives me a great pleasure to introduce to you Dr. Jennifer Ross, who's a physician scientist, who has been an assistant professor in our division since 2022. Dr. Ross grew up in Salem, Oregon, earned a bachelor's degree in genetics, cell and developmental biology from Dartmouth. Then she moved to Atlanta as an emerging infectious diseases laboratory training fellow in the CDC Division of Parasitic Diseases and conducted diarrheal disease research in Peru. She then went back to the West Coast and completed medical and public health degrees at Oregon Health and Sciences University. She began studying tuberculosis in Uganda while she was an internal medicine resident in the Global Health Pathway at UCSF. She came to UW in 2013 for her ID fellowship training and then completed a Fogarty Global Health Fellowship in Uganda during the research years of her fellowship. After appointment to the AID faculty, she also spent time as a visiting fellow and faculty member at the Institute for Health Metrics and Evaluation. She completed a career development KO1 award, modeling TB prevention among people living with HIV in Uganda. And Jen is also a staff physician at Seattle VA and maintains a VA epidemiology research portfolio, mostly in COVID. So welcome.
Thank you very much for the opportunity to be with you all. It's really an honor to give this talk. Thank you, Anna, for that kind introduction. I have to warn everybody that every time I practiced this talk, I found more things that I wanted to say. So these are topics that I love to talk about, and I really appreciate everyone's attendance, both the folks that are joining here in the room and folks that are joining on Zoom. I won't be talking about VA research today, but I do have a VA position, and as Anna mentioned, currently my VA research mostly focuses on COVID, although I'm working to bring in some TB research to the VA portfolio as well. So I do want to thank the Fialkow family for their generous support of this award. I also want to thank my family. My husband Dave is here in the audience, our daughters, and our extended family for all of their support of my research career. And then I want to acknowledge the more than 25 years. So I started working in a lab as a high school student, started working in a lab at Oregon State University. So it's more than 25 years of scientific mentors, collaborators, colleagues, and mentees who have shaped my career and all of the research that we've done together. Before I get into all of the talk, I want to spend a moment thinking about the title. Population level progress on HIV and TB prevention in the PEPFAR era. And maybe the PEPFAR part wasn't part of the original title, but I added it in. So why talk about population level? Well, although I am an infectious disease clinician and I treat individual patients one at a time, the population level is where a lot of my research interests lie. I'm very interested in how infectious phenomena affect populations, how they move through populations, how they coincide within populations and with other societal phenomena, and then how our treatments and our prevention strategies can be applied across populations to prevent infections and then prevent infectious disease mortality. And so many of the studies that our research group develops use tools of epidemiology, math modeling, and implementation science. And I'll be talking about several of those today. And then I also wanted to frame the talk about focusing in the PEPFAR era for a couple of reasons. One is that it's been a massively impactful program that has faced, unfortunately, significant disruption in 2025. And I think it's an interesting lens to view somebody who developed a career in the era in which I did, because the timeline aligns pretty well with my career and I think frames some of the way that I approach certain research interests. So as you may have gathered, this talk includes both scientific research as well as some kind of personal narrative. We're all being encouraged at this moment in particular to share some of our personal history and talk about why our research is important and how research impacts us. So I'll talk about my introduction to a career as an HIV co-infection researcher, some shocks and my perspective on them as an early career researcher. And here I'm talking not about the physiologic process or state of shock, but more of an economic term where a shock is something that comes in and is a massive disruption to any trends that may have been occurring. And then I'll spend the later portion of the talk talking about my current research focus on HIV prevention among households affected by TB. So we'll start in 2003 for introducing an ID career. And in all honesty, I was an ID person from a very young age, so I think we could go back even further than this. I suspect I'm not the only person in our division who may have done their fourth grade social studies project on the plague. But I'll start this part of it in 2003, which is the year that I was graduating with a degree in genetics, cell and developmental biology. And this was a fascinating time to be studying cell biology. Not only were we working with the model organisms of plants, worms, E. coli, and yeast, flies in there, but we also were working with HIV as a model system for learning about genetics and how the HIV can co-opt the cell's machinery to copy itself. So here shown in the illustration of the right is an illustration of the HIV virion fusing with the host cell, using its reverse transcriptase to transcribe the viral RNA into DNA, then integrating with the host cell genome, later using the host cell machinery to transcribe the DNA into mRNA, which is then translated into protein and broken up into small particles of proteins by a viral protease packaged into virions and then sent forth to infect new cells. So at the time, this became a model for learning about different ways of genetic regulation. It was also exciting because, as shown in the orange boxes here, there were ways that had been discovered to interrupt these processes, and we were using those as drug targets or as ways to treat HIV. And so shown here in orange, we have the fusion inhibitors, which were only available IV and didn't have were not massively used, but then also the non-nucleoside and nucleoside reverse transcriptase inhibitors that form the backbone of HIV treatment, along with the newly developed protease inhibitors that had really changed survival in high-income countries. And they were being used, as shown in this figure here on the left, to massively decrease deaths due to HIV. So in this figure, which is taken from a cohort of people with advanced HIV across US cities, people who are living with a CD4 count of less than 100, we see that deaths in the early 90s before the use of combination therapy are hovering about the 30 per 100 person years line. And then with the scale up of combination therapy, we have a significant decline in deaths, at least in the high income country setting. So this was a very interesting time to be coming into a field where we could really be optimistic about ways to introduce therapies to people living with HIV. And I'll just acknowledge that as a difference from many of the people who ended up being my teachers in medical school and in residency and in fellowship, I never knew really professionally an era before HIV treatment was developed and was available in high-income settings. And a lot of the questions that were really challenging us at this time were scaling up therapy and also making it less toxic and more acceptable, as well as ways to prevent HIV acquisition. So I had been learning about HIV. I had been taking microbiology, TAing the course, loving it. Our graduation was impacted by SARS-1. And this was also the year that PEPFAR started, which I'll talk about in a minute. So to give a little bit more context of the state of HIV in the early 2000s, at this time it was estimated that there were 36 million people living with HIV globally. You can see here in the figure that the majority of people living with HIV lived in sub-Saharan Africa, more than 25 million. And in the figure on the right, which has panels at 4 different years in the early HIV epidemic, 1984 through 1999, you see the HIV prevalence among adults ages 15 to 49 increasing through that time, and by the end exceeding 20, in some cases even into the 30% in countries in Southern and Eastern Africa. So there was a massive challenge about scaling up treatment. And this was having population level impacts. So this is data from the Our World in Data program showing that countries in sub-Saharan Africa had been experiencing increases in life expectancy through the 1950s, 60s, and 70s that were then reversed with the effects of HIV in the 1980s and 90s. One country that has a little different pattern here is Uganda, which is shown in green, which is where I do most of my research, and where life expectancy was already declining due to war, even before HIV made things worse. So there was a massive research gap in data from WHO, or resource gap, excuse me. ART was available in many high-income countries, although not, at least in the year 2003 data, not widespread everywhere. This figure was only citing a 29% ART coverage in Canada, but up to 79% in France, and very low, of course, in countries in sub-Saharan Africa, 1% here in South Africa and 2% in Uganda. And there was a belief at the time that it may not be feasible to provide HIV treatment in low-income settings, that perhaps it was too complicated. But there were organizations at the time that were countering that narrative and effectively providing HIV treatment. One of them was the AIDS Support Organization, or TASO, which had been founded in 1987 in Uganda, and was one of the organizations that influenced how PEPFAR was shaped. Another one was Partners in Health, founded by Paul Farmer and Ophelia Dahl, where they were providing treatment both for HIV and TB in Haiti, Peru, and Russia, and which was featured in a book by Tracy Kidder, mostly about Paul Farmer, published in 2003. And so at the time, there was a growing global investment in HIV, with the Global Fund to Fight AIDS, TB, and Malaria, started in 2002. There was a campaign between the WHO and UNAIDS to initiate 3 million people on antiretroviral treatment by 2005. It was known as the 3x5 campaign. And then there was PEPFAR, which was something that George W. Bush introduced in his State of the Union speech in January of 2003 and was approved by Congress to spend $15 billion for use in 15 countries, mostly in sub-Saharan Africa. The program was to provide ART to 2 million people and prevent 7 million new infections. And this time, the prevention strategies relied mostly, or emphasized mostly, the prevention of mother-to-child transmission, and then behavioral modification through abstinence, be faithful, use condoms, ABC strategy to prevent sexual transmission. As we understood more about HIV, we also became increasingly aware of a crisis in HIV co-infection, where the impact of HIV on the population was not just through HIV itself, but also through massive increases in associated infections like TB. So HIV markedly increases an individual's risk of developing active TB disease and then dying. And TB has been cited as the leading cause of death among people with HIV globally for as long as I have been reading and citing papers. It was in Liz Corbett's 2003 article in The Lancet that way, and it is still that way. We see here in this figure on the left, the massive increase in TB case notifications that's occurring alongside an increase in HIV prevalence among people seeking care, antenatal care in Zimbabwe. And TB was my entry into studying the population level impacts of HIV, which I began studying as a resident at UCSF. So while I was there, I worked with Dr. Luke Davis, who was a pulmonologist at UCSF, and was working in 6 public sector health facilities in Uganda. And Luke was working on ways, along with Achilles Katamba, in particular, our Ugandan collaborator, working on ways to increase the likelihood that people would complete their full evaluation for TB. This is a time when TB was diagnosed with light microscopy. So we didn't have fluorescent microscopy, we didn't have gene expert, we had light microscopy, and people were asked to come back to the clinic on multiple subsequent days. So it was not uncommon for people to not complete that full evaluation. And in this case, where we were able to observe data from more than 260,000 adult visits to clinic, we found that 40% of people did not complete that evaluation. And we wanted to explore why and what could be done to increase that, or increase the number of people who are completing their evaluation. And one of our hypotheses was that people who had to travel further to go through their whole evaluation might be less likely to complete it. And so it was suggested at a meeting that I learn how to analyze geographic data. And I was not initially a fan of this suggestion. In fact, I think I was very upset about it to the point that one of my colleagues pulled me aside later and said, "Are you okay?" Because I thought it was not a reasonable residency research project, and it wasn't. It ended up taking me into fellowship to really work on this, but it was something that I got so into and really enjoyed and ended up setting me on this trajectory. So I guess that was one word of advice, is that sometimes things that you think initially are not going to work out or not be a good idea can kind of surprise you. So what I did is I spent some time with the folks at the Berkeley Department of Forestry, who taught me how to use some basics in ArcGIS. And what we did is we used some satellite data and information about road networks to try and predict how long it would take people from different parts of Uganda to reach our clinics. We were only able to locate our clinic patients to their home parish, which is the 4th level of the administrative unit in Uganda. But then we constructed what's known as a friction surface. So something that takes multiple layers of the land cover and the road network and tries to figure out the shortest route to get to clinic. We found that patients who are seeking care for TB were traveling further than people who are coming for other reasons. It's not totally surprising because TB diagnosis is only available in certain centers. And at this point, we found that travel time did not predict the likelihood of completing TB evaluation. There were a lot of limitations to this analysis, but it set me on a road of starting to think about exploring these types of questions using spatial methodology, which I continued into fellowship and had the opportunity to work with Simon Hayes' geospatial team at IHME on several of these projects, where we were working on the top left in collaboration with folks at the Brazilian Ministry of Health to use small area estimation to look at TB and HIV mortality. And then we competed in a competition sponsored by the Stop TB Partnership in collaboration with the Pakistani National TB Program to estimate TB prevalence across different regions in Pakistan. And one of the strengths of these methodologies is that they use TB or HIV surveillance data together with covariates in models that leverage the spatial structure of the data. And this is important because in most areas of the world where TB and HIV are common, there's not perfect surveillance data for every part of the country about how many people are actually acquiring these infections or dying from them. And so there are areas where the counts are low or incomplete, or areas where sampling is just not available. And so we can leverage the data that we do have, along with factors that go along with TB, like crowding, like poverty, like HIV, to be able to make some predictions for areas that are unsampled. And these efforts have applications in informing TB active case finding, which is important because globally we estimate that about 30 to 40% of people with TB are not identified and start on treatment. They're also important for tracking the progress in reducing incidence and mortality. So we went on to develop another methodology here that's shown in the right to model TB incidence in Uganda that ended up being part of my K. So checking it on another time point, it's 2018. PEPFAR has been reauthorized several times. It's now 15 years old. It's gone on through PEPFAR to provide treatment to 14.6 million people. Prevention has started being included with not just behavioral strategies, but also VMMC And I also had a K that was funded, working with my mentor, Rand Barnabas, on modeling approaches to prioritize TB prevention among people living with HIV in Uganda. So this was a very important year for me. I'll spend just a moment talking about TB preventive treatment. I know it's very familiar to the people in the room, but that's really the key intervention that was the focus of my K. TPT is, of course, offered to individuals who are at increased risk of developing TB in order to reduce that risk. And I'm purposely not saying latent TB here because we've really reevaluated a lot about TB natural history in the last few years. It's important that critical, in fact, that we assess for active TB disease before initiating TPT, because we wouldn't want to undertreat someone with active TB disease with only the medications used for preventive treatment. And it leverages the relatively slow progression of TB relative to many other infections. Of course, there's a big trade-off here in that most people who are at risk for TB don't go on to develop active disease. And so there's been a lot of research over the years in identifying the people who are most likely to benefit from TPT and in developing shorter and safer regimens. So the first study that we did as part of my K was looking at what is the benefit of TB preventive treatment when it's given with ART. Because we know that treating HIV with ART also has a substantial benefit in reducing the risk of developing TB disease. And there had been a couple of studies, clinical trials conducted in high incidence TB countries. So the Temprano study and a study led by Lele Ngaka and colleagues in South Africa that had documented this. And one of the interesting things that they found led to kind of our motivation, which was really about the subgroup analysis for these trials. So we did show in doing an individual participant data analysis that providing TPT along with ART reduced the risk of developing active TB disease by about a third when compared to ART alone. But if you look, and I apologize, this is a teeny tiny table, but over here, we were interested in whether that benefit was limited to folks who had evidence of immune sensitization to TB, either through a positive tuberculin skin test or an interferon gamma release assay. And we found no evidence of a difference in benefit between the folks who are TST or IGRA positive or negative. And that supported what had been the WHO recommendation and remains that TPT not be withheld in scenarios where, in settings where TST and IGRA are not available. One other benefit of doing this individual participant data meta-analysis was that we had access to great data from these trials. And we were able to use those data to help parameterize models of now not just what is the benefit to the individual person in terms of preventing TB, but what happens if we were able to massively scale up ART and TPT. And we had the benefit of working with people like Rand Barnabas, my mentor, who showed models of community-delivered care that could actually achieve very high levels of viral suppression and TPT initiation and treatment in a sub-study led by Adrian Shapiro. So we set to work creating a model that's shown on the right here that would allow us to simulate TB and HIV transmission in a community like communities in South Africa where TB incidence was very high. And then something happened. Well, multiple things happened. So I just want to take a little bit of a detour into some of the shocks that I mentioned and my perspective on them as an early career researcher. So the shock that I'm talking about at this point was, of course, the COVID pandemic, which happened when I was an acting faculty member And I have to say that being an acting faculty member trying to join the permanent faculty was very stressful. And it was especially stressful to do at the time of the COVID pandemic when so many things were being disrupted and everybody was feeling isolated. It was really stressful for me and for my family. And I have to believe that it's even worse for faculty who are, or senior fellows and acting faculty who are trying to make the same jump now. Because the uncertainty that we were having then, at least there was a lot of research money that was becoming available for studying COVID. And the situation now is really uncertain. So this is an aside, but I think it is very important and in the spirit of the award that we all continue to recognize how important it is to support our junior researchers as they transition to research careers. There was also another shock that happened specifically to us along in this timeline, which was that in April 2023, one of our children was diagnosed with cancer. And this was a terrifying situation where you go in for an outpatient study, and instead of going home, you go to the emergency department and get admitted to oncology. It was really, really scary. And I'm so thankful to share that after more than a year of intensive treatment, she's doing great. Thank you. Thank you to everyone in the room who's applauding. But I think it's also given me perspective on some things that were really helpful about the way that the division stepped up to support us, the way that our colleagues stepped up to support us and my research career during that time. This was a time when certain parts of my job felt really hard and some felt easy and almost like a welcome break. And so there were certain parts of my job that I wanted to continue doing and really appreciated being able to do. And then there were some things that were just really hard. It was hard for me to lead meetings. And I really appreciate the colleagues and Dave Horn in particular, who's in the room here, who stepped up to support my mentees. Our administrative team in AID made the process of taking leave very smooth. And I'm so grateful for that, as well as they provided reassurance that my job and health benefits were safe. I had help sharing the news and updates. I had a particularly great offer that may be kind of an unusual thing, but I wanted to highlight because this is, I had the opportunity to give a high profile talk. This was a time when I felt like I probably could, but that I might have to step away with less than an hour's notice. And so this was about our VA research study, and Javed Shah, who was working on the VA research with me, offered to be involved at every step in the preparation process, and if I needed to step away at the last minute to give the talk. And I really appreciated that. Thanks to everybody who fed us for 8 months, and to Anna for keeping us warm and caffeinated. I often have struggled with what to say with folks when folks face similar challenges. And this was a resource that a friend found and sent to us that really resonated with me. There's several good examples here of things to say and things not to say to families who are facing cancer, but one of them is particularly easy, I think. And I've copied it here, just the message that I think of you often and I wish you every good thing for you and your family. I received that so many times. It was always welcome, and I use it now in a lot of different settings. You don't have to be original. I think just being earnest is really good. So I wanted to pass that along. I also wanted to say that our family has benefited from being part of clinical trials, and we continue to participate now in trials among survivors. The Children's Oncology Group which is largely supported by the National Cancer Institute, is an amazing and very important resource that absolutely needs to continue receiving support. So thank you to everybody who's involved in oncology research. I know it's a lot of work to run clinical trials, and it's essential. So we'll go back. This is one of my houseplants that's now blooming, which has been a great interest to develop alongside some hard times too. So with the remainder of the time, I'd like to return to a current research focus for our group, which is HIV prevention in TB-affected households. And I'm just double checking that I have 12:35. Okay, good. Tell me when I'm going over, okay. Thank you. These are fun things to talk about. So this returns to the theme of pandemics or infections that are overlapping, that are co-occurring in populations, and the theme of HIV and TB service integration. So HIV and TB are epidemiologically linked, as we've talked about, and it's been guidance for a long time, at least since 2012, from WHO, to make both sets of services available at the same time and in the same place to make person-centered care. And so the guidance included in this advice is that TB programs should implement HIV testing, care, and prevention for patients and their partners. And something that I haven't talked about yet, but has been happening alongside all the TB stuff, particularly with a lot of involvement from UW researchers, is all of the research into biomedical HIV prevention. So this is a graph from a figure from the Partners PrEP study, which is a study among HIV serodifferent couples in Kenya and Uganda, showing that compared to placebo, taking daily oral PrEP with tenofovir or tenofovir emtricitabine, known as Truvada, markedly reduced the risk of acquiring HIV, of transmission happening within that partnership. And so the work that we were doing on preventing TB among people living with HIV and the work that was happening around me and in many research settings on biomedical HIV prevention inspired a new interest, which is looking at really the dynamics of HIV and TB within an affected household and thinking about ways that we could leverage the public health interventions happening for TB to also prevent HIV. So there's a public health strategy to visit the household of people with pulmonary TB and to screen their close contacts for active TB disease, and if they don't have signs of active TB disease, to start them on TB preventive treatment. These contacts are at high risk for developing TB, and we know that TPT is effective. Well, in settings where HIV is also common, HIV testing is recommended for those household contacts. And we see from several articles from different settings in Uganda that those household contacts often have HIV prevalence that exceeds the prevalence in the surrounding community. So the household contacts are more likely to have HIV. What hasn't been incorporated, at least at this point, is any sort of referral for PrEP among people who test negative for HIV, despite now we've shown that there's high efficacy of PrEP in preventing HIV acquisition. So we began exploring the potential opportunity to link people in households that are affected by TB to ART if they test positive, or to PrEP if they're eligible and want PrEP. And we've pursued this through a couple of different directions. This is work that's supported by a CFAR New Investigator Award that was mentored by Ruan Barnabas. In one strategy, we used a secondary analysis of data from a clinical trial to ask whether TB household contact evaluation was an efficient strategy to encounter serodifferent couples. And then we also developed a math modeling framework to estimate the potential impact of linking serodifferent couples to ART and PrEP. So I'll talk about the math part first. Ultimately, we evaluated 4 different settings. These are 4 different countries that are all a part of the WHO high burden list for TB and HIV, but they all have some different dynamics. For example, in Ethiopia, TB is very common, HIV is much lower. Other countries have higher HIV prevalence. There are also places where we do a lot of our work and would find these sorts of estimates to be useful. And so the diagram on the right then describes or illustrates a framework where we're combining data from lots of different sources to try and get at these estimates. We're using the population, the FIA surveys shown at the very top, as well as the demographic and health surveys, putting those together with global burden of disease data and with information from the literature. And one study that was a sub-study of this that I wanted to just highlight on its own was where we estimated the number of household contacts and their age and their sex for people living with TB or with pulmonary TB in many different countries. And to do this, we used estimates from the Global Burden of Disease study at IHME. We took out only the fraction of people who had pulmonary TB because people with exclusively extrapulmonary TB would not be infectious to their household contacts. We looked at the age and sex patterns in those data, and then we combined them with data from the demographic and health surveys or from census in countries where the census was available to look at the way that household size was distributed. So household composition by age and sex. And then we developed a framework or incorporated a framework that allowed us to quantify the uncertainty in those estimates to make estimates for the 20 countries with more than 80% of incident TB about what would be the age and sex composition of all the household contacts. And we found that in a country like Uganda, for example, which is kind of in the middle, we estimated that about 2% of the population would live in a household with people with someone with pulmonary TB. And it differed a little bit by age group, with the highest proportion being among people ages 5 to 14. And this varied by country, with the highest proportion being in Zimbabwe, and then some other countries that are included in the high burden list, but actually have lower population rates of TB, Russia and China, all the way on the right. We fed these estimates back into the model, along with several other sources of data, to come up with what we thought the prevalence would be of HIV serodifferent couples in TB-affected households in each of these 4 countries. And we focused on serodifferent couples because they're a group that benefits from PrEP, and they're also a group for which data are available, or at least estimates. They're not the only group that benefits from PrEP, of course. But we found that in Kenya, for example, we estimated the prevalence of serodifferent couples in HIV-affected households to be about 15.7%. And you can compare this to the figure on the right, where we would expect that in the general population, if we weren't just looking at TB-affected households, it would only be about 5.7%. So this is showing us that we think that, yes, looking at TB-affected households is probably an efficient strategy for finding people who could benefit from PrEP. And we went on to estimate the number of people that we expected could benefit from PrEP in these households in each country. I also want to mention briefly an analysis, secondary data analysis we did of a clinical trial that had been conducted in Uganda by my residency mentor, Luke Davis, Achilles Katamba, and their colleagues. I won't go through this perhaps in as much detail here, but the households where people had pulmonary TB were visited, and community health workers screened everybody for symptoms of TB and offered folks who were negative for active TB disease, TB preventive treatment. And they were also randomized then to receiving HIV testing in the home or referral for care. So we used the data from this study to identify what was the HIV status of couples within these households as a way to kind of confirm what our modeling showed. We were not able to identify all of the couples in the households because we really only had information about how each person was related to the person with TB. But among the couples that we did identify, which was 115, we found that 18 were serodifferent for HIV, which was 15.7%. Again, about twice as high as it was in a comparison survey among cohabiting couples in Kampala from the similar era. So more support for the idea that going to households of people with TB and screening for HIV and PrEP would find people who could benefit. As I mentioned, there were some limitations with this work, so we were not able to assess for all of the couples. We had incomplete data on their engagement in HIV care, so we didn't know if someone was already virally suppressed and their partners would be unlikely to benefit from PrEP. We also didn't assess for other HIV exposure. So all that to say, that led to some good preliminary data for our next proposal, which is our R01. So this is what we're working on right now. The TB PrEP study was funded in late 2024. It includes an implementation trial to assess the implementation and effectiveness of home-based HIV self-testing and PrEP versus standard clinic referral. We also have a qualitative component, and we're doing a cost-effectiveness analysis. 2025 has brought more shocks. I don't have to tell anybody how disruptive everything has been this year to research. We've seen the PEPFAR 90-day pause and then a limited waiver that allowed treatment to continue, but PrEP only for certain high-risk groups, certain eligibility criteria of pregnant and breastfeeding women, and not other groups that may be supported with PrEP. We've had the loss of USAID, which of course supported tuberculosis programs across the world. Other things that are included here, loss of HIV funding, cuts for HIV research among key populations. And then more recently, just in September, we've had the introduction of the America First Global Health Strategy, which was supposed to include bilateral agreements being developed between the US and different countries that were going to be developed between October and December of this year. And with the government currently shut down, I can't imagine that any of that is going forward. So there's been massive disruption. And my mentee, Kai Tram, who's in the audience here, got right on this and published this early paper estimating that due to cuts in PEPFAR treatment funding, at least 100,000 lives would be lost in that 90-day pause. Other groups have estimated the number of new infections that would occur as a result of limiting PrEP to only pregnant women and breastfeeding women and not to other groups. So we are in a challenging place globally for our HIV-associated research. But personally, this is where we are, which is still working on the TB PrEP study. We are still funded. This is a picture of our team in Uganda at one of our participating study sites. We've developed the protocol, we've engaged all the sites. We're waiting for one last IRB approval before we activate, which I'm hoping to report our first enrollments by the end of the month. Oh, I've included this just to show what a challenge it is right now to also to do an implementation study where you're trying to develop an intervention that will incorporate into the standard of care. And right now we have a changing standard of care. So folks in our group or folks in our study who are in the control group are being referred to health facilities for HIV testing and PrEP initiation. But depending on what's going on in global funding, it's been really hard to figure out how available that is. Fortunately, in Uganda, PrEP is still available for all of the eligible groups in the facilities in our region. So just in a final slide here, I want to highlight that the TB PrEP study is just one of the many studies looking at ways to make HIV prevention more available and acceptable. These are other efforts by UW-affiliated groups or UW-affiliated investigators that are working on making PrEP available in pharmacies or integrating with family planning, surveying the ways that we can make HIV prevention more acceptable. So I appreciate everybody's attendance at the talk today. I appreciate very much the generous donation and support of the Fialkow family in supporting this award. I want to thank all of the research mentors, collaborators, colleagues, and mentees who have been on this journey with me. And it's always risky to list names because inevitably there are people that I've forgotten. But thank you to everybody who's had a part in this. And thank you to our funders. I'm happy to take questions.
Thanks, Jen, for that talk. I have a general question for you. As you said, there were all these shocks in the system. It's not an easy path to become a physician scientist. What advice would you give to a young fellow coming out who wants to be a physician scientist? What would be your advice to put them on the pathway to success?
Thank you. We're laughing because I'm looking at one of my mentees in the back row here, it's a challenging time to know how to advise people. And I have to say that I had the good fortune of getting to spend some time with my mentor, Ruanne, earlier in the summer. And I just came up to her and said, I have so many things I want to ask you, because it is really hard. I think one of the ways that I've been advising people is generally to keep going, the work that we're all trying to do, and to come up with some backup options as well. You know, we've been looking at ways to do research with funding from different sources. I've applied for my first industry grant in a while recently, and trying to find ways to diversify the support for our research. Because it's clear that it's needed, it's clear that it has benefits, and we love doing it. So I think it is undoubtedly a really tough time. I think it's really tough, especially for junior researchers. But I'm hopeful that we'll be able to keep people going.
Are there other questions from the in-person audience? Anna, go ahead.
I actually had a TB question for you. I was surprised that the benefit of preventative therapy was, if anything, even greater in people that were IGRA negative. And you mentioned that you were using it to recommend that people are given that regardless of IGRA. But if IGRA is available, would you still want to give it to people that are IGRA negative?
Yeah, I think that is a great question. And I have not been in the room or the virtual room at WHO where those policies are being debated. I mean, I have a couple of explanations for that finding. So one is that we know that people with advanced HIV may not respond to a tuberculin skin test or an IGRA the way that somebody whose immune system is functioning would, because they would both of those tests rely on some sort of immune function. But these were people who were taking ART. So I don't think that's likely the explanation at play. The explanation that may be more likely in this setting is that these were really high TB incidence settings, and they may have prevented some new TB infections. The TPT may have prevented some new TB infections during the course of the time that people were taking treatment. We know that the majority of TB transmission or the TB disease in high incidence settings is due to recent transmission. And so there is some benefit to folks while they're on treatment as well in a prevention against a new infection. But it is striking, like it wasn't statistically significant in the positive group. I mean, there was, so I'll say that from the main effects analysis, there was a higher incidence of TB in the IGRA positives and the TST positives than in the negatives. But that hazard ratio was more dramatic in the negatives.
We have a comment and a question in the chat. The comment first is from Dr. Barnabas. Say, congratulations, Jen, on doing outstanding work, communicating so beautifully, focusing on people and building new knowledge. We are so fortunate to have you in academia. And the question is a personal spin on Conrad's question here. You talked about how your residency project was not a practical residency project, but it was really interesting to you. How did you push through during that period of time, and what advice do you have for trainees who are often struggling between joining more ambitious projects that really interest them versus ones that will lead to papers possibly more quickly to help build their portfolio?
Yeah, I mean, it's another really good question because clearly there are trade-offs either way. I didn't get that paper out for 3 years, and it took a lot of work. And I was fortunate to be working with a great mentor who was willing to kind of stick with me through that, even after I moved to a different institution. So in general, I think in general, it's good advice to right size a project for the time that you have available to do it. But I think it's also, especially during your training, in either residency or fellowship, to think about the skills that you can acquire during those training periods and how you can look to potentially time beyond your current situation or your current institution to building a research niche. So I would say some of both.
Thank you for a great talk. And I'm so excited your mentor is watching, maybe from Boston or somewhere else in the world. So that's super cool. I'm going to stick with the theme of asking about the stuff that you shared about kind of your journey, because I think that's really impactful for everyone in the audience. And one of the things I was struck by is you've done a great job of crossing silos and working with folks who aren't only in infectious diseases or only in pulmonary, but partner with IHME, partnered with I don't remember who they were that helped you. Who was it?
Forestry.
The forestry folks. Like, we don't usually cross into the forestry space. So I'm wondering if you have some thoughts about how to break down silos, how to make those partnerships across different disciplines, and how it's been meaningful to you, because I thought that was an interesting part of your story.
Thank you for that question. I really love that question. And I, at one point, even kind of looked into like academic literature about cross-disciplinary collaboration and like some of the ways that it goes well. So yeah, I routinely collaborate very closely with mathematicians, epidemiologists, with engineers. I mentored a student in industrial and systems engineering who ended up programming that model. I didn't include a slide of the model that got disrupted by the shocks, but we did end up doing it. And I think I really enjoy it. So there's that like personal interest. I think it's really fun. I like, just like we would with a patient care where we come to a situation and try to think about what's best for the patient and resolve conflicts that way. I think we come to a collaboration situation thinking about what are we curious about? What do we want to discover? And then what can we each bring to it using our different knowledge and approaches? So I think it is really good to, on a practical note, to get used to talking about TB without using terms like basically or obviously or any of the sort of like subtle language that could make it hard for people to engage with us when things are not basic or obvious to them. But then bring in, I mean, I guess just a genuine enthusiasm for this type of work. I enjoy talking about infections with people, and so that's fun.
I will give you the last word here since it's at the top of the hour.
Hey, Jen.
Hi, Kai. Thanks for coming.
First, a comment. I can say that you're definitely underselling your mentorship skills, and I say that from personal experience. You're an amazing mentor. My question is, how do you translate your mathematical modeling results into policy decisions, or how do you have those inform actual policy discussions?
Yeah, and I think you could answer that very, very well too, with a lot of policy experience. So I'm curious to talk more about it with you. I think one of the things that we've tried to do in our work is to engage the policy folks early on so that they, the folks from the National TB program in Uganda, for example, were involved in developing the research questions and then in developing, participating in discussions about which factors were most important to include in the models and be able to see so that they felt ownership in the research process and they could understand and use the results. So we knew they were going to be relevant for them. So that is something that we always try to do in our work. And then we probably all have to talk about our work more in spaces that are less comfortable for us. So this is a very comfortable space with a lot of supportive researchers, but get used to talking about our work in settings outside of academics.
Well, it's at the top of the hour, so I'd like to congratulate Dr. Ross on receiving the Fialkow Scholar Award for 2025. And thank you for the talk, and thank you for your attendance.